Hi, I'm Venu Menon. I'm the section head of clinical cardiology at the Cleveland Clinic, and I'm also program director of our Cardiovascular Fellowship program. Welcome to our feature highlighting research published by the Cardiology Fellowship. And today I'm delighted to have Erika Hutt, who is a first-year cardiology fellow who just joined us earlier this July. The use of the WATCHMAN device has been really useful for us in cardiology because, as you know, atrial fibrillation has a significant thromboembolic risk, and compliance as well as the ability to tolerate Coumadin is limited in a large number of patients, which renders them vulnerable to stroke as a result of atrial fibrillation. And so Erika has this wonderful paper in the HRS journal where she highlights a vulnerable group of patients that were really underrepresented in clinical trials. So Erika, tell us a little bit about your study and the group that you identified that needs further clarity.
Yes, of course. So patients with a history of intracranial hemorrhage or any kind of major bleeding were actually excluded from the clinical trials that led to the device approval by the FDA. So there's a lot of unanswered questions when it comes to this patient population where we don't really know if they can tolerate the short-term anticoagulation that they need to be on for the after WATCHMAN implantation. So we created a registry of patients that actually did receive a device even with a history of intracranial hemorrhage and any major bleeding. And because these patients were excluded from clinical trials, we thought that we could find, just see what their outcomes were and if they were able to tolerate anticoagulation after WATCHMAN.
That's really interesting. Tell us a little bit about the team approach that is required before you take a person with a prior intracranial hemorrhage and consider them for a procedure like this?
That's a great question. So I don't think a lot of people are brave enough to put these patients on anticoagulation at all. So you definitely need a multidisciplinary team, meaning you need to have the neurologists involved, sometimes neurosurgeons, definitely the cardiologist, and then the electrophysiologist. There's a lot of just multidisciplinary meetings where they discuss patients. There are some patients actually get imaging after their intracranial hemorrhage to show stability of the hemorrhage before considering anticoagulation. Some of these patients were challenged with anticoagulation before going for the procedure for a short period of time in a way to make sure that they would not bleed. Because as you know, these patients have to be on 45 days of full anticoagulation after WATCHMAN implantation. So it's really a multidisciplinary approach.
I'm sure that's really challenging, and I think this is a really nice insight into a very vulnerable group of patients. So why don't you describe for us the characteristics of these patients and what you found?
So as you can see in slide 1, patients were elder. They were 73 years of age mean, and their CHA2DS2-VASc scores were very high. So 5.0 CHA2DS2-VASc score, and these patients were really completely, as I said, excluded from trials, not only because of the history of intracranial hemorrhage, but also underrepresented, meaning that they're much higher score, CHA2DS2-VASc score than other patients. So multiple comorbidities, as the CHA2DS2-VASc score will tell you, and also very high bleeding risk.
And what did you find, and how was this procedure? Was it safe? What did you guys find?
Yeah, so in terms of the outcomes, what we really see is that there was, in a year of follow-up, there were no strokes in these patients. There were no intracranial hemorrhage, which was sort of our main or the most important finding, that we didn't see any repeat intracranial hemorrhage. There was one minor bleeding, and it was really just a hematoma around the site of implant. And then there was one mobile echo density or just device-related thrombosis that was identified at day 45, and this patient was continued on longer anticoagulation without any adverse event.
So the bottom line of your study is that there is certainly a group of patients with intracranial hemorrhage who have ongoing risk for further embolic events due to underlying atrial fibrillation, in whom a WATCHMAN should be considered, and with a team-based approach, many of them can be protected from future embolic events in the future.
Exactly. So most of these patients after an intracranial hemorrhage, while being on anticoagulation or even not being on anticoagulation, everyone sort of gives up on their stroke protection strategy because no one is really willing to anticoagulate these patients, but the WATCHMAN comes in as an alternative way of protecting the patient from stroke. So again, I think that not everyone will qualify to this. When we were discussing sort of which patients are elected to have WATCHMAN, it really depends on what the mechanism of the intracranial hemorrhage was, what neurologists, they want to know if it was a spontaneous hemorrhage versus a non-spontaneous, and then if it was subdural versus intraparenchymal versus subarachnoid, if it was traumatic or not. So all of those things are taken into account before considering a patient for WATCHMAN implantation.
Congratulations on your manuscript and for
you.
highlighting this really vulnerable group of patients.
Thank you, Dr.
Congrats, and thanks for watching this podcast.